I'm clearly audible for everyone.
Good evening.
Good evening. Yes. So, hi everyone. I welcome you all for today evening session. And today is the third module of geriatric rehabilitation session. And today is geriatric syndromes. So, everyone understood the last two modules what we had discussed about the introduction and also about the assessment and evaluation.
Yes, ma'am.
Okay. Great. So today we'll be starting with geriatric syndromes. In this, we'll be learning um, few contents like falls and balance disorders, which is majorly seen in geriatric population. Second is frailty and sarcopenia. Again, the second most important thing. And third is osteoporosis and fractures. Is everyone with me? Any difficulties yet? Okay. So can anybody tell me what is fall basically? What do you mean by fall? Very simple. Anyone can answer.
Loss of proprioception that leads to loss of balance, ma'am.
Perfect. Okay. Anything else? Anyone? Okay. So very correctly mentioned. Falls is a most common occurrence, most common factor, most common symptom the patients come in older age. Okay. And one fall can have major serious injuries or could be minor injuries. Okay. So falls in older adults are common occurrence and may lead to serious injuries like head injury or fractures. Recurrent falls. Recurrent means multiple times or multiple events of falls are frequent and that are majorly responsible for the overall morbidity and mortality in older adults. It points towards an overall poor physical and cognitive status of an individual. The fall is a symptom, it is not a disease. It can be multifactorial and it can be interrelated. Can anybody make me understand that? What do you mean by symptom and not a disease? Can anyone elaborate on this part?
Ma'am, please repeat the question.
The question is why we consider fall as a symptom but not a disease.
A fall happens due to an outcome of an underlying conditions. So say a
Very
person
correct.
is suffering from vertigo
Okay.
and they lose balance and they feel dizzy and they can have falls many times. So here we see where the fall is just a symptom of what is actually happening internally.
Perfect. Very correctly mentioned. So, fall is a symptom. It can happen through multiple reasons and multiple factors. And as a physiotherapist, your job is to find the correct factor, the correct problem, and then treat that. Hence, it is a multidisciplinary approach. It requires to prevent and treat any injuries that have sustained from the falls. About 30 to 50% of these falls result into minor injuries, and about 10% of the falls can lead to major injuries. Is everyone with me? Did everyone understand what is fall and why it is important? And it can also tell us about the considerable morbidity and mortality in older individuals. More the falls, higher the chances of mortality and morbidity. Always remember that. If the person has less number of falls, the person is more fit, the mortality and morbidity chances and occurrence will be less. So, what are the different risk of falls? Okay, always remember there are different factors which can lead to fall. First is an extrinsic factor, which is something around in our environment. Second is the intrinsic factor, which is inside our body. Third is a situational factor. Okay, in extrinsic factors means environment. Most commonly, what we see is in the night. Many patients have falls in the night, specifically into bathrooms. Correct? Am I right or wrong? You might have heard taking histories, right? रात
Yes, ma'am.
को वॉशरूम के लिए गए थे पर दिखा नहीं ट्रिप हो गए या बाथरूम में गिर गए and that leads to multiple fractures, specifically femur and pelvic bone fractures, most commonly seen in older individuals. So, the major concern for extrinsic factors is poor lighting or some glares from the lamp, poor or no personal equipments or assistive devices, unfavorable floorings, which are uneven floorings, slippery floorings, loose carpets, or some objects which are lying in the middle, obstacles like electrical cords, steppers, thresholds, or low-lying furnitures or slippery shoe wears. Okay. So these are the most common extrinsic factors what we see that can lead to fall. One good thing is we can modify these factors, we can change these factors, we can eliminate these factors. Yes or no?
Yes,
Yes,
ma'am.
ma'am.
Yes.
Yes.
So this is the most important thing what I'm mentioning for an occupational therapist. These, what you see is an environmental assessment or environmental evaluation, what we discussed yesterday. These are the major reason why you should actually see where they are sitting, see where they are living, change the factors so that it is more friendly environment for the old individual and the chances of falls reduces. Okay. Second is an intrinsic factor. Intrinsic factors usually we can't change, but we can definitely modify and we can definitely maintain. First is a disease which alters the gait and mobility. Which are the different diseases? It could be Parkinson's, could be new knee or hip arthritis, feet problems, neuromuscular problem, neuropathy, vestibular problems. So any of these things which can be easily managed and can be modified and can be trained, but they cannot be removed from the body. Second is medicines. So many patients who are on sedative drugs, it is always mentioned them to not move around in the house or going outside because these medicines have a peak effect where the patient feels drowsy and sleepy and can fall. This is one good example. I'll give it to you. I had a patient. She was around 75 years of age and she had burning sensation and tingling numbness in her entire body. Okay. So she had back pain also, obviously with age related. So she came to me. So I asked her that what medicines the doctor is giving you. So she told that my doctor is giving me pregabalin 75. So pregabalin is a GABA transmitter or a GABA neurotransmitter medication which helps to calm your body, which helps to calm your nervous system, right? So once your nervous system is calming, it works on the central nervous system. That's when the person constantly feels sleepy, constantly feels lethargic, constantly feels lousy, not doing anything. At that time she was extremely very sleepy. She was in the kitchen and she forgot to switch off the gas stove. Okay, so that happens, and she suddenly, somebody in the house started smelling some smoky, pollution, and then they immediately came into the kitchen and they closed off the stove. So these are few risky things which can happen. Even the falls can happen. Sometimes a person can also have burns. Okay, so make sure that when you see that these patients are on such drugs, you have to make sure that at that particular time they should not do any activity, or else they should always have somebody with them. Third is visual impairment. Obviously, we need vision to walk, right? If any of the vision is affected, like cataract, glaucoma, macular degeneration, retinopathy, make sure that it is being treated with some kind of operations or medicines or eye solutions to make sure that the vision is proper. Hypotension basically is when they are standing, they will have sudden drop of BP and they will fall. That is also one of the reasons. So always check hypotension. It is very commonly seen. It's called as postural hypertension. When the person is suddenly sitting and standing, the BP will drop and suddenly they will feel that I am feeling giddy and they will fall. So always check blood pressure in such patients while changing the position. And increasing age. Increasing age basically, obviously, if you feel the person has a very poor muscle strength, poor muscle coordination, no good stamina, the entire joints are very stiff, the patient is not able to walk, and they are losing balance. Again, that are the factors of falls. Everyone clear with extrinsic and intrinsic factors? Any difficulty?
Clear, ma'am.
Okay. Next is the situational factor. Situational factors means anything in whichever situation you are and you are doing something and suddenly you have a fall is called a situational factor, like walking and talking. So it's a dual task. Always remember, dual task or multitasking gets very difficult with aging because their cognitive power is reduced, their overall functional activity is reduced. So whenever you want to train the old age people, always make sure that you do dual tasking activities and multitasking activities. Then is being distracted by multitasking. Falling, failing to notice any environmental hazards like steps, rushing to the bathroom at night, rushing to answer the phone. So these are this will never get fall, but if the person is not ready, if the person's joints are not strong, if the person is not cognitively aware, or the person's is stamina or the endurance is not good, that can lead to fall. So even the situational factors is what you can train the patient so that they will not get falls. Everyone clear? So these are the different factors which you have to assess in your assessment. Specifically, ask in your history, check their environment, check the amount of the activity they do, check their strength, and then see which was the major factor of fall, and always modify and change them. Everyone clear?
Yes, ma'am.
Okay. Now we'll go to the pathophysiology of falls. So why falls happen? We have understood what is fall, why it is common in geriatric. We have understood the different risk factors, but why that fall is happening? So an important cause of fall in the older adults is a presence of sarcopenia. Can anyone tell me what is sarcopenia?
Loss of muscle mass, severe
Correct.
loss of mass.
Muscle
Severe
mass
loss of
loss.
muscle. Yeah, loss of muscle mass. Correct. Imagine our body has to move. How will they move? With the help of muscles. If the number of muscle fibers or the muscle units are reducing with the age, the person will not get good strength. If there is no good strength, the bone will not move properly. If the bone is not moving properly, the person will not be able to control themselves, and that can lead to falls. Generally, older adults will have decrease in mass volume and coordination difficulty. Specifically, they have a loss of white fibers. So how many types of muscle fibers we have in our body?
Three,
Any?
type 1, type 2A, type 2B.
Okay. So which are the most important? Can anyone elaborate on the different types of muscle fibers?
I think a slow twitch and fast twitch, right?
Yes, that is also correct. And also there are different classifications. You can consider any of them. So why the white fibers are more, lost in older adults? What is the difference between slow twitch and fast twitch fibers or the white fibers? Anyone? Physiology is very important for us to understand. If you understand that, then you can treat it properly.
I'm not sure, but is it due to something like fat deposition or something? Or
Yes. Mm, very true. Perfect. So as we know that if in our body there was 100 fibers when you were at your peak age, with the age that 100 fibers is going to 25 or 20 fibers. So the extra space is there is being converted to fat. If you're not training the patient very well, there is a more muscle mass is reduced and there is more fat mass. And specifically the white fibers. White fibers are slow twitch fibers. Slow twitch fibers basically are anti-gravity muscles, anti-gravity fibers. These fibers work against the gravity for a long time, or they are also called as postural fibers. So these postural fibers will go down. The posture will not be maintained. That's why you see many people have forward head postures, kyphotic postures, and they are walking in a kyphotic manner. That becomes means their postural muscles are weak. So they are not, their stamina of the muscle is reduced, and that's why the coordination is poor and the fall can happen. Another cause of fall is the presence of cognitive impairment, specifically in the older individuals who have chronic illnesses, pain, mood changes, depression, or any kind of dementia or Alzheimer's. Postprandial hypertension is a non-physiological reason. It is commonly seen in old age people. Why? Because with the age, your autonomic nervous system, your receptors, which usually sense your blood pressure and the changes of blood pressure, goes blunted. The response is very slow to the higher center, and suddenly when the person stands up, the BP will fall down, and the person might feel giddy and can have fall. Obesity in older adults is also one of the major cause of falls, because the extra space has been occupied with the fat and the less space is occupied with the muscle. So the muscles don't have enough strength to take that amount of fat mass load, and that's why the fall can happen. Osteoporosis. What is osteoporosis?
Something related to bone is more like loss of calcium and porous, increased porosity in the bone.
Okay, very close, but it is basically called as loss of density of the bone is called as osteoporosis. That can cause the rupture of the bones, that can cause falls, and if the bones are very soft, they are spongy, and the person falls, that can lead to fractures. The most common type of fractures what we encounter as a physiotherapist or the occupational therapist is the pelvic bone fractures and the femur fractures. Another cause is an increase in the percentage of fall is decline in the strength of the diaphragm muscle. So why it is important? We know that our core is made up of four muscles. One is diaphragm, one is transverse abdominis, one is multifidus, which is the back muscle, and another is pelvic floor muscle. With the age, all these muscles go for weakness. Okay, if any of these core muscles are weak and the person is not able to balance the main axial skeletal system, obviously the falls will increase. Everyone clear? Any difficulty with the pathophysiology? So one is sarcopenia, second is a higher mental function, which is a cognitive problem. Third is a cardiovascular system where it's a postprandial hypertension, very commonly seen. Obesity, which is one of the metabolic disorders. Osteoporosis, which is specifically the bone problem. And the next comes is your major core.
And can you please once again explain that the type of fibers related to this fall?
Yes, I will explain. So in our body, we have specifically two type of fibers. One is a slow twitch and one is fast twitch. There are different classification, but we'll go with this. So slow twitch fibers are the fibers, specifically are the white fibers. Okay. Fast twitch fibers are the red fibers. Slow twitch fibers are basically, they take longer time to get activated and they have good endurance and they can work for a longer time. So these fibers are specifically present in postural muscles. Postural muscles basically are the muscles which are working against gravity. Okay, so with the age, this against gravity muscles or these postural muscles will lose more white fibers. If they are losing more white fibers, their posture will be altered. When the posture is altered, they will have different posture like forward head, rounded shoulders, kyphosis, genu varum. They are walking in shuffling gait. Their balance is challenged. Once the posture is changed, your center of gravity will change. And once the center of gravity will change, the chances of fall will increase. Clear?
Yes, ma'am.
Okay.
Ma'am, what about the red fibers?
The red fibers will be there, but the number of the units will be reduced. But still, the red fibers will be more in number as compared to the white fibers, always.
Okay, ma'am. Thank you.
No problem. So we have discussed about falls. Now the risk of falls, what is falls, the pathophysiology of falls, what assessment you have to do and how you have to evaluate and come to the picture which was the main reason of fall. So now why the fall happens? The fall basically happens because of loss of balance. What is balance? What is
Misalignment
balance?
in the center of gravity, ma'am.
You're not audible. I'm so sorry. What?
Misalignment with the center of gravity.
Okay. So basically, balance is basically where stability, exactly. So balance definitions is basically is maintaining the stability in any object or any surface area where the entire weight of that particular object is maintained in the center. Okay, so in our body, our center of gravity is maintaining the balance between our body, and our center of gravity is just present ahead of the S2 level, which is the sacrum 2 level. Okay, so if any alteration in our balance will change the center of gravity, and if the center of gravity is going outside the base of support, that's when the balance going chances will be higher, and if the balance is going, the fall chances will increase. So again, balance has many, it's again a symptom. It has many reasons, as it is multifactorial. So as a physiotherapist and occupational therapist, we need to come to know which is the exact reason why the balance was gone. So aging and aging related diseases such as stroke, traumatic brain injury, Parkinson's are very closely related to the psychological changes like motor, sensory, and cognitive function. The most common cause of balance in the elderly population is age related because of the decreased muscle mass and bone mass. Second is postural instability. Third is BPPV, which is called as a benign paroxysmal positional vertigo. Then is vestibular neuritis or Meniere's disease. These conditions can overly affect the patient's ability to perform the activity of daily living, that increases of risk of falls, and also can lead to total dependence on the person. Balance disorder in older individuals can be influenced by multiple factors, could be age related in sensory system like vision, vestibular or somatosensory, could be musculoskeletal system, specifically bones and joints and muscles. Then it could be cognitive factors, basically the higher mental functions, or it could be because of any internal medical conditions. Everyone clear till now? Any difficulties?
I'm clear, ma'am.
Okay. So now, as you can see in this picture, very clearly, you can see on the left hand side, there is an old age person. Okay, there are different reasons why the balance can be gone. One is the degenerative neuropathy. Degenerative neuropathy, with the age, your nerves will have reduction in the conduction. They will degenerate, and because of that, the receptors are sending the signal very slow, and before that, the person can lose the balance and fall. Second is reduction in the nervous conduction system. Third is the vestibular function. Again, with the age, there is a degeneration in the vestibular function, which actually is a major uh, organ in the body to maintain the balance. If there is any problem in the vestibular system, the balance will be challenged. Then is a visual impairment. Visual impairment, basically your eyes. Eyes will tell you whether you are standing where you are standing. If any vision problem, which is most commonly seen in age related, can also have loss of balance. Then is degenerative spinal deformities like kyphosis, extreme lordosis, or any spondylosis or arthritis, where the bone joint or the major joint surface is affected, the person cannot walk, can lead to falls. Then is the functionality of the joints and muscles. If the bones are very spongy, they are not good, they are porous, the muscle mass is less, sarcopenia, osteoporosis can overall reduce the activity of the joints. When the activity of joints is lost, the proprioception function is lost, the joint sense is lost, kinesthetic sense is lost, and that can also lead to loss of balance and then can lead to fall. Everyone clear? Any difficulty? Yes, no?
Clear, ma'am.
Yeah. So now
Yeah.
I want everyone to give me any one assessment. How will you assess balance? Anyone can answer. Just give me different ways how to assess balance.
By doing time up go test for dynamic balance and functional reach test for static balance.
Okay, before going to this outcome measures and special test, what is the core balance testing? Can anyone tell me?
Force
Work
state
balance scale.
balance. Yeah.
Works balance scale again is a scale and an outcome measure.
Four
Before that,
states
what?
balance.
Rhombus standing test, ma'am.
Single leg
Yes,
standing.
exactly. Go for the simple test, standing. So you can always start with basic, static balance and dynamic. Static balance means if the person is sitting, okay? In sitting also the patient is losing balance or not. Sometimes many patients who have Parkinson's, who have postural instability, the patients who have Alzheimer's, or patients who have tremors, will, even in sitting also, they will keep moving from one side to other side. Patients who have stroke, they will always go to their paralytic side. So that means the static balance is only a problem. Then is the dynamic balance. Dynamic balance means you have to ask the patient to stand in one place and give them reach outs in different direction outside the base of support. If you see that standing is a problem, means the dynamic balance is a problem. So if you see that the patient is not able to do reach outs, they are having fall. Okay. So that means the dynamic balance is an issue. So first go for these basic testing. Then you can go to different scales and outcome measures. There are different outcome measures. The most commonly what we use is work balance scale. Then you can definitely, if you want to see the balances going in gait while walking, you can also check with DGI, which is a dynamic gait index. You can always go for functional reach test, which is again a out of base of support test. Then you can confirm with these tests that the balance is affected. You can get a value, and once you start training them, you can again check the value to see the difference. Everyone clear?
Yes.
And before going to balance testing, you have to thoroughly assess musculoskeletal system, nervous system, and cardiopulmonary system. If all these three systems with the balance, you have to correlate which is the system is affected. If the patient comes to me and she's telling me I'm feeling extremely dizzy and I cannot walk, but I can sit properly. So I will not check her bones and muscles first. Rather, I will go to check her vestibular system. I will check her higher mental functions, and I will check her blood pressure in different positions. So make sure that the history what you're taking is correlating with the assessment what you're doing.
Ma'am,
Everyone clear?
yeah, ma'am, can you just repeat those few points that you just said towards the end?
Yes, I will repeat that. So I'll just take an example of a patient. Suppose a patient is coming to me and she's telling that I'm having a loss of balance. I'm feeling giddy and I'm feeling dizzy when I'm changing position in the bed, and I cannot walk because I'm constantly feeling very dizzy. So my first understanding will be to check her vestibular system, to check her higher mental functions, and to check her blood pressure in different positions. If any of this is affected, I will understand this is a problem. But if the person is telling that I'm feeling dizzy constantly, so dizziness doesn't have any relation with the musculoskeletal system. So always check for the most important thing, correlate which system is affected, which balance is affected, static balance, dynamic balance, or walking balance, and then start training the patient. Don't just randomly just do bug balance scale, this is affected, then I'll just train the patient like that. No, you have to do every system analysis, then go to the balance testing, then go to the coordination testing, and then come to the reason, find out the reason and the impairments, and then go to the treatment option. Clear?
Yes, thank you.
No problem. So, what are the different signs of balance disorder which we usually see in our patients, and the history what the patient is? The most common early sign of balance problem is constant feeling of instability. They cannot stand, walk properly on a flat surface. The sensation what they usually describe that the ground is moving, or they keep tripping over the daily objects, and the balance is affected. Difficulty in maintaining an upright posture. They usually slump or go into one side is also one of the early signs of balance. Feeling dizzy, which could be because of vertigo, and clumsiness over the work, and struggling to perform 2 to 3 tasks at the same time. So these are the signs of balance disorders which you have to see in the patient. Second, you have to ask in the history. Third, you have to assess every joint to find the impairment, and then only go ahead with the treatment. Clear?
Yes.
Okay. So make sure that you ask these things. If the patient is not telling, it's okay, but you have to go and ask these symptoms to see whether anything is problematic or not. Comfortable? Just a minute. Everyone understood? Yes, no? The signs, what history you have to specifically ask, and what things which can be missing from us or the patient is telling to us. Clear with falls and balance? How do you check? How do you see? How do you ask history? Which are the factors? Which are the different systems which can be affected to have balance problem and fall problem? Okay. So now the next topic we are going to is frailty in old age. Now, what is frailty? Can anyone tell me? What do you mean by frail?
Weakness.
Okay, very good. Anyone else?
Difficulty to progress a task.
Okay, okay. Anyone else? A better understanding?
Having a more higher probability of falling more often.
Okay, okay, that's good. So everyone, I think all three of you have mixed together to give one answer. So frail basically is a synonym of weak. Okay. So when we hear a word as weak, we all obviously correlate with old age. Okay. Because in old age, obviously the patient will go weak, right? So frailty means in older adults decreased physiological reserve. Now, what is physiological reserve? So reserve is something which is present in our body. Now, physiological means muscles, bones, posture, receptors, or different systems in our body. If any of these reserve is less in our body, which will be decreased with old age, that means a person is frail. Okay. So the major things what the patients or their family members will tell, वो इतने पतले हो गए हैं, they are not eating well, they can't even sit on their own. Before she was able to walk till the hall, now she's not able to walk to the bathroom also, right? So these are the symptoms of frailty. More the frail the patient, higher the chances of morbidity and mortality. Always remember. Okay, because if the patient is constantly lying down, there is no energy, they will not do any activity. If the patient is lying down constantly, obviously there will be lot of loss of muscle mass, loss of bone density, bluntingness of the receptors, and again all the morbidity will increase. Okay, and also that is one of the factors of risk of fall. Okay, so patient's frailty index is the most accurate predictors of the adverse events after the fall and can also tell us about the morbidity and mortality of the patients. One significant difference in a geriatric population is skeletal fragility, which means that the bone's muscle mass is less and that can lead to risk of traumas, balance issues and falls issues. So many patients who are elderly have multiple severe injuries, and that is majorly because they are very frail, their bone mass and muscle mass is not good, and their overall functional status and health is very poor. If they have multiple falls and the person is frail, their overall dependence will increase and the quality of life will be poor, and that can lead to more hospitalization. More the hospitalization, more the mortality and morbidity. Everyone clear?
Yes.
Okay. So if you want to measure frailty, there are amazing scales which are out there on internet for you, where you can measure the frailty. Like there is one outcome measure which I really like, which is a frailty index score. Okay, it's a very nice score. We usually take in ICU patients. Okay, because majorly these ICU patients will have post ICU weakness or post ICU bedridden or post ICU weakness and frailty. With these scores, it is very easier for us to start treating every component of the frailty and then see whether the scores have improved or not. You can obviously use these scales in your clinical setup as well, but these scales are more betterly worked in ICU patients. Clear with frailty, everyone?
Ma'am, can you repeat the last point in the frailty?
Yeah. So the last point which I mentioned was the different outcome measures. There are many outcome measures in for measuring frailty, but one of the good outcome measures which I usually take in ICU and hospitals is a frailty index score. That frailty index score, it helps us to understand how frail is a patient. And there are different components in that. Okay. Is the patient able to stand? Is the patient able to sit? If any of this is a problem, you will train the patient accordingly and see whether the scores are better or not. Okay, because these skills are usually seen in ICU patients because they are lying in ICU for a very long time. And as you know, bedridden patients have more complications, right? So you have to start the physiotherapy in the ICU only. You have to continue the physiotherapy to the inpatient department and also to the outpatient department. This is
Mhm.
something which is very missing, and this education is what you have to give to the patient. Even if they get discharged from the hospital to house, you have to continue physio at house also to come outside the post ICU weakness. Clear?
Oh, okay. Okay. Clear, ma'am. Thank you.
Thank you. No problem. So everyone clear till falls, balance problems, then frailty, any difficulties, all whatever we are speaking today are interrelated. Okay. These are not different topics. These are all interrelated symptoms, and all these symptoms can together be also present in an older individual. Okay. Next is sarcopenia. So as everyone has told me before, sarcopenia is basically decline in the muscle mass. It is derived from a Greek word. Sarc means flesh, penia means loss, where it is telling that decline in the muscle mass, basically the muscle strength and the function. It is often associated with the older adults, but some form of sarcopenia can also affect the middle-aged people. So nowadays, sarcopenia is most commonly seen in the middle-aged people also because of constant sitting job, very less amount of physical activity, constantly chairs sitting, usually seen in engineers, IT workers, people who have desk job, because their physical activity is absolutely zero. Okay, so nowadays the sarcopenia is starting to hit middle-aged people also because they have no amount of physical activity. When there is sarcopenia, it is always related to higher amount of weakness, which is frailty. Second, low energy because the muscle mass is not there to do any amount of activities, and more independence. Sorry, more dependence, and reducing the quality of life, and also can increase the chances of loss of balance and having falls and risk of fractures. Sarcopenia is more likely related to people who have chronic diseases, and that can also contribute to risk of factors, falls, fractures, and other serious injuries and mortality. So, why sarcopenia is associated with chronic diseases? Can anyone tell me the correlation? It is very important, actually. This line which I'm telling. How chronic diseases like hypertension, diabetes mellitus, metabolic disorders, or thyroid is linked to sarcopenia, or cancers. Cancer is also one of the chronic diseases.
Uh, I feel it's more like your physiological processes are altered when you have chronic diseases, like diabetes mellitus or thyroid or cancer or hypertension. And I think somewhere it it relates to muscle, like due to blood or something, blood work, changes in blood work. I mean, I might be wrong.
Oh, you're truly very correct. Perfect. Nothing wrong. Anyone else?
Ma'am, is this linked to protein breakdown in the muscles?
Yes. Okay. Protein breakdown. It is again obviously seen in older individuals, but why with chronic diseases? Okay, detrimental effect, loss of muscle mass. Okay, so everyone is telling is going on a perfect line, but there has to be a proper explanation. So every chronic disease what we have in our body is coming with chronic inflammation. Always remember. Okay, disease will just not come without a problem or chronic. It always comes with a chronic inflammation. Whenever there is a chronic inflammation that causes lot of high oxidative stresses in our body. Whenever there is a higher oxidative stress in our body, that starts damaging, that starts hitting every organ, every system. For example, take an example of diabetes mellitus. Okay. So diabetes mellitus is a condition people usually tell it is something related to pancreas, it is something related to sugar. No, but diabetes is actually a metabolic disorder which affects every system of our body. So how it is affecting the muscle? So when there is chronic inflammation, when there is diabetic problem, there is higher amount of the sugar levels which are going inside the bloodstream. When there is higher sugar levels inside the bloodstream, the patient will not use the sugar levels. It is not using the sugar for the energy. So how the body will take the sugar? First is from the fat. Once the fat is also gone, second comes the protein. Where the protein will come? It will come from your muscle. So it will start breaking down your muscle. And that is why all the diabetic patients usually feel more hunger. They will have very less muscle mass because the protein is getting breakdown. And because of chronic inflammation also, there is a higher oxidative stress that will keep breaking the muscle. And overall, the muscle quality and the muscle strength will go down. Everyone clear?
Yes.
Clear,
How will
ma'am.
you, yes, so how will you see sarcopenia? You can definitely do a DEXA scan. DEXA scan is a outstanding scan, or else entire body sonography, or there are BIA machines also which will tell us the exact body fat percentage. They will tell us the muscle fat percentage, and also in DEXA scan you can see the total amount of the muscle mass, where it is present, how much is it present. In the simpler manner, you can always go for the circumferential measurements also. Okay, there are 7 circumferential measurements. There are different way how you can measure the muscle mass. So if you can do that, please make sure to ask these history in patients you feel are in having diabetes or hypertension in more than 15 to 16 years. Okay, so these chronic injuries can also chronic illnesses will also have sarcopenia. Poor nutrition, lack of exercise can also increase sarcopenia. As we know, weight bearing exercises have been proven according to research to improve your muscle strength and muscle fiber and muscle endurance. If you're not doing exercises, not doing overloading principle, your muscles will lose, and again, the muscle strength will never get better. And again, people who do extreme diets, not giving good nutrition, not giving good protein, micro and macro proteins to the body, that can also lead to loss of muscle fiber. Clear?
Yes.
Okay. Now we'll go to osteoporosis. So we have spoken about muscles. Now we'll speak about bones. Osteoporosis weakens the bones to a point that they can break easily. It is called as a silent disease. So nobody will ever come to know that their bones are spongy or porous or their bones are weak. They will never come to know. But it always comes with signs. And that's why it is called as a silent disease. What are the different signs of osteoporosis? First is loss of balance, loss of mobility, loss of muscle strength, constant pain in the entire body. The things what they were able to do before with ease is getting more difficult. Okay. The patient, even if walking for 5 minutes, is having clumsy gait. So these are the signs what you have to start noticing. Then you can come to know the whether it could be osteoporosis. How to confirm osteoporosis? Again, with the help of DEXA scan. It is a scan which helps us to understand the bone mineral density, and there are different ranges in that. One is a normal range, one is a osteopenia, and then is osteoporosis. Okay, so in the range, if the patient comes, if it's osteopenia, with the help of body weight exercises, aquatic exercises, and strength training, it can be reversed. But in osteoporosis, the patients usually have to take few injections, exercises, and maintaining their lifestyle. Okay, so osteoporosis in older adults can be caused because of imbalance between the remodeling process, where there is a in balance between the resorption and absorption of the body, and also the making of the new bone. This altered process of bone remodeling causes your bones to lose the mineral density, creating the large gaps form in the framework and causing the bone to become weak and prone to fractures. The symptoms are decreased body weight, shortness of breath, multiple fractures, back pain, and postural instability or movement instability. Everyone clear? So as you can see in this picture, on the left hand side, you can see how healthy bone it is, very compact. The framework is perfect. It is in one line. But in osteoporosis, you can see many holes, right? These holes makes the entire bone very spongy, very porous, and sudden one crack from outside can lead to multiple fractures. So there are different risk factors of osteoporosis. So first is the postmenopausal. As you know, with menopause, your estrogen hormone, which is a very good hormone for female, reduces. And when this reduces, the chances of osteoporosis increases. Old age, because obviously the bone mass will reduce. Medications, there are certain set of medications, specifically cancer-related medications like radiations and the oral medications have seen and have been proved by research to reduce the muscle mass and also the bone mass. Endocrine disorders like diabetes or thyroid or any other metabolic disorders, inflammatory diseases, hemopoietic diseases specifically, which has a problem with bone marrow, and nutritional disorders like anorexia. So these are the major risk factors which will lead to osteoporosis. And osteoporosis, always remember, it's an imbalance between the remodeling and the bone resorption and the new bone formation. If there is an imbalance, the bone will not be grown and there will be constant process. Clear?
Yeah, ma'am.
Okay. Again,
Yes.
when there is osteoporosis, there is loss of balance. When there is loss of balance, there is falls. When there are falls, that can lead to fractures. And when there is fracture, again, there will be bedridden for these old individuals. When there is bedridden, obviously there are bedridden factors. So it's a vicious cycle. So when you have to break the cycle is the most important thing for us as a physiotherapist and the occupational therapist. In the aging population, the bone mineral density is assigned the T-score. If the T-score is higher than 1, it is a healthy bone. If it is between -1 to -2.5, it's osteopenia. If it is more than 2.5, it is osteoporosis. So now we'll come to fractures. If there is osteoporosis, if there is falls, that can lead to fractures. So fractures are the major complication of the fall in these older individuals. Specifically, 10% of the falls cause fracture and 2% usually is involving the hip, which I already mentioned before. Estimated 75% of the vertebral and the non-vertebral fractures occur in 65-year-old individuals, and more than 75 years of people have hip fractures. Fractures are independent predictors of long-term mortality. Quality of life may be deteriorated significantly after the fall in majorly older people, which for them it is very difficult to regain the original amount of the mobility. Ultimately, a decreased activity can lead to loss of muscle weakness, stiffness in the joints, and may also contribute to reduced mobility. So, fractures for old people, it is not very great because when they go for bedridden, there are further complications which are added, and it is very difficult for us to manage that. So which are the most common factors what we see in old age people? One is a Colles fracture. Why it is most important? Because whenever the person is falling, the first thing what they keep is hand to protect themselves. So when they keep the hand, the wrist will automatically impact the ground, and that impaction can cause a Colles fracture. Second is a proximal hip fracture, most commonly the head of the femur or the IT fracture or the neck of the femur. The majorly it is managed by a total hip replacement, partial hip replacement, or PFN, which is a proximal femoral nailing, majorly is done in old age individual. If it's a young individual between 50, 60, dynamic hip screw can also be done. Ankle fractures, post proximal humerus fracture. Again, when they are falling, if they are falling on one side, the first bone which comes into contact is the humerus and the femur. Then is metatarsal fractures and also osteoporotic wedge fractures. So some patients, even if they are having no fall, no history of fall, no history of trauma, can also develop vertebral fractures or the spinal fractures. Why it is happening? It is specifically happen because of the compression. They suddenly sit very fast. They get sudden pressure on the spine, and there can lead to compression wedge fractures in the vertebral spine. These fractures are very commonly missed. They will normally come with back pain to you, right? They will come with back pain. You are treating everything, everything is fine, but the patient's pain is not reducing. Then you do an X-ray and you see that there is a compression fracture. It is very important for you to first see X-ray if the patient is osteoporotic to rule out any fractures. Clear?
Clear, ma'am.
Yes. Okay. So today, as we have mentioned about falls, balance, the major reasons, sarcopenia, osteopenia, frailty. So this picture I have taken from the National Institute of Aging. Okay, this comes under WHO. These are it's a very nice demographic information what they have made in an infographic where they tells about the 6 tips how to prevent falls. Okay, specifically talk to your healthcare providers to see whether if they have any medicinal side effects. Second, do strength and balance exercises, which is a part of physical therapy and occupational therapy. Make the home safer for the old age individuals to use grab bars, night lights, having bars in the bathroom, securing the carpets and floors, which has to be done by the occupational therapist to see the environment. Correct your vision and check your hearing regularly. Stand up slowly to avoid postural hypertension or giddiness. Use the assistive devices wherever required. Have a good lighting. Remove the loose ends from the floor and make sure that the house is very clean and neat and free of objects. Clear?
Uh,
Yes, ma'am.
whatever
And
you
clear.
said right now, is it there in somewhere like that we can read? It's the same website that you said, right?
Yeah, if you go on NIH Aging, you'll find all this information there, whatever I've spoken in today's session. So
Oh,
everything I've taken from all research articles, from WHO guidelines, and from National Institute of Aging.
yeah. Thank you.
No problem. Everyone cleared? Any difficulties? Okay, this is
And
almost the same thing which I've taken from that. Yes. Clear? Any doubts? Everyone understood?